deformity is corrected, this will be appropriate. And then you can continue lengthening again with the 6 axis. So length and alignment achieved, and then you put in straight rods, and those 6 struts can go on to the next patient with regular Ilizarov rings for use. So economically it becomes much more sort of sensible. So at 6 months, all of these problems of his are corrected. That is his alignment, and that is him walking. He now has, because we put on a fixator on the distal portion of the femur, he now has a stiff knee, but that has been corrected since with a quadriceps plasty. Okay. So again, in complex situations, it's a good idea to have this kind of a tool well, but to underline again that this does not take away from any of the, you still have to apply all the principles of Ilizarov. Where will I do the osteotomy? How do I correct it? Where is the cora? Nothing changes. This is something which will make it easier for you to carry it out. So therefore, I think the younger people, if some of the stuff looks a little complicated in terms of the frames, etc., you know, the Ilizarov mechanisms are getting better in terms of ease of use. Thought process, still it's only your brain which will do it. Thank you.
Fixed axis system applicable to foot and ankle deformities?
Absolutely.
Or is it? How do you plan it, because the axes are not different?
Yes, but you can plan. I don't know whether I have it here. If you'll permit me, I'll show you that. I didn't include that for, you know, to keep it brief.
I request Dr. Mauricio Catani to hand over the one photo.
I want to. Yeah. Give it to me. Give it to me again. So
yeah. I request Dr. Mauricio Catani to hand over the memento to Dr. Hitesh Shah. Now we carry on with the foot and ankle session. Again, we are bringing in one non-Ilizarov subject. We have a expert foot and ankle surgeon with us, Dr. Amit Bhargava, who heads the Department of Foot and Ankle in Fortis Hospital, Noida. He will speak to us regarding the non-Ilizarov option in foot and ankle deformities.
Good afternoon, everyone. It's, I would say, quite difficult to follow Dr. Mangal Parihar as he steals all your thunder before. I am Dr. Amit Bhargav. I work in Delhi at Fortis Hospital. I am a non-Ilizarov surgeon, partly because it's quite difficult to manage Ilizarov in private sector. It requires quite a lot of input, and corporate sector is not very forgiving. One thing is true, that Ilizarov is very forgiving. Margin of error is there. You can go in and correct your mistakes. However, if you are doing one-stage corrections, then there is no margin of error. You need to understand the deformity, whether the deformity is caused by soft tissue forces or the bony forces. And unless you balance the forces, which means that you address both the soft tissues and the bones, you cannot correct deformity without an Ilizarov. So this is a lady with what we call as hallux valgus deformity. And you see that she had quite a severe deformity, for which on one foot someone has done a second toe amputation. So she lost her second toe because of the deformity. And that actually didn't solve her functional problem because she was getting pain underneath the second toe because her first toe wasn't working. Now, until unless you understand that, if you treat this, the patient becomes worse than before. So what actually we need in this is to make the first toe weight bearing, to take the pressure off from the second toe, to help the patient functionally. So that was done on the second side, where you see we have corrected the big toe, made it the weight bearing area of the foot, so as the rest of the foot can be offloaded and patient can not only cosmetically but also functionally improve. This is another deformity which there is hallux valgus not only on the big toe but a reverse of that on the fifth toe, and it's called as bunionite. So the main issue here is that the feet are so wide that they can't fit into the shoes. So the foot has been made small and made weight bearing from either side by doing osteotomies so that a person can find good shoes. A rheumatoid patient. These patients present to you with metatarsalgia. They can't walk because the joints have subluxated. And this is the X-ray picture. So to keep the patient in Ilizarov for these deformities, it's difficult. This is one-stage correction. We have fused the MTP joint and we have excised the lesser joints by following some simple basic rules. The foot shape has returned and she has become weight bearing and it's easy for her to walk and wear normal shoes. This is another rheumatoid patient, a lesser of a deformity, and here we don't have to excise the joints. We could salvage it and make her foot straight. And this is the result after 6 weeks. Another common clinical problem I see in my practice is flat foot deformity. This we call as acquired flat foot. These patients were normal to begin with. They had normal feet, and as they grew, for some reason, the foot has become flat, and it's difficult for them to walk. The main reason for this problem is dysfunction of tibialis posterior. So here you see an example. On the left, you see a patient with acquired flat foot where the foot was normal. You can compare it with the other side. When the foot becomes flat, the heel turns out and it goes into valgus. And there is usually a mid-foot break at the talonavicular joint, leading to talonavicular stress. So this is corrected by transferring another tendon in place of tibialis posterior and doing a calcaneal osteotomy to correct the heel valgus. This is the post-op X-ray of the same patient. Flat foot is a spectrum. You need to understand that causes of flat foot can range right from the ankle to the talonavicular joint, midfoot, Lisfranc injuries, tendon problems. All these can cause flat foot. So it's very important to make out what the cause is. And all of these are addressed differently. So this is a patient who came, he's 18-year-old, he plays badminton, and he's going to go to university next year. So he wants to get the deformity corrected because it's now giving him pain while he plays badminton. And these are his X-rays. So at some stage, it looks like he had growth arrest of the lateral part of the distal tibia, leading to this deformity. So it's a multiplanar deformity. We plan it like this. We get a CT scan done. We get a 3D mold constructed by using the software. And we can draw your osteotomy, even make cuts, and put your implants on and pre-plan it before doing surgery. This is a malunited tibial peel-on fracture with varus of the ankle. It was corrected with the opening wedge osteotomy of the distal tibia. This is an interesting patient. He came to me at the age of 34. He says that at the age of 18 years, he jumped from a height and he sustained a fracture of his ankle, which was treated conservatively. If you look at it carefully, then he seems that he had a talus fracture, which has malunited, and it is causing osteoarthritis of the medial compartment of the ankle joint. He's 34 years old. He does not want ankle fusion. He has got good range of movement. So he wants some relief for his pain so that he can manage his day-to-day activities. These are his feet. If you look carefully, that there is varus deformity of the right foot, and that's leading to a lot of pressure on the medial compartment. So we planned osteotomies for him. This is called as profundoplasty. You do opening wedge osteotomy of the medial malleolus. You decompress the medial compartment, and you also correct the varus of the heel. This guy is now about 18 months from his surgery. His pain has improved, and he's able to live and do all his day-to-day activities. This is another patient. This patient is a young patient. He has osteoarthritis localized to the anterior compartment, anterior and lateral compartment of the tibia. So he had an osteotomy where we transferred the weight-bearing axis to the posterior part, and this is his post-op result. Another similar patient. So in multiplanar problems, you need to understand the deformity, plan it properly, get 3D models reconstructed, draw your osteotomy, maybe make cuts before going to surgical intervention so that you get better results. In this one-stage surgery, you don't have any margin of error. You need to get it right absolutely on table. This is another kind of a problem. This is a fracture in a patient with a skin like this. So it's a difficult problem. Usually such situations happen in Charcot joints in diabetics. So this is the answer in such situations. If there is a skin problem, you use a nail. If the skin is okay in a patient like this, you can correct this deformity by using fibula as an intramedullary rod and supplementing it with a plate outside. My videos are not working, but another deformity which I commonly deal is the cavus deformity. I had excellent lecture of malingomyelocele in the morning, and I try to deal with the same deformities by joint salvage procedures. Here are a few examples. This is a young chap. He has got cavovarus foot, and he has developed a non-healing fracture because of the deformity. And you can see the fracture at the base of the fifth metatarsal. So he came to me because his fracture is not getting better. He has been in plaster for 2 years, but the fracture is not healing. And the reason why it's not healing is that when he walks, he puts all the pressure on the base of the fifth metatarsal. And that's the reason why it has broken in first place. So unless you correct the deformity, this is not going to heal. So how you correct the deformity? You address where the problem is. In this case, we did a calcaneal osteotomy, which corrected the heel varus. We excised the base of the fifth metatarsal, so the pressure point has disappeared. All this has led to supination of the forefoot, so we corrected the supination by plantar flexing the first metatarsal. So that's the main issue in correcting these deformities in one stage, that you need to understand the mechanics of the foot thoroughly. You can't just depend on something to do the corrections for you. This is a patient who had an abscess in the lateral part of the foot, and someone did the debridement, following which he had nerve injury and he was left with this deformity. So again, the main deformity here is equinus cavus invarus. He has posterior release. I'll show you his video later on. And this is the results when he comes out of plaster in about 3 months' time. So posterior release corrected the equinus, transfer of tibialis posterior tendon to the anterolateral part of the foot corrected the varus. So correction of cavo varus in adults require one or all of the following procedures depending upon the deformity. Plantar fascia release, tendon transfer, usually it's tibialis posterior, corrective osteotomy like calcaneal or metatarsal osteotomy, mid-tarsal arthrodesis if there is arthritis. Usually all the cases I am showing you, we have salvaged them without arthrodesis. Triple arthrodesis if there is osteoarthritis at the talonavicular or subtalar joint. Jones procedure for clawing of the big toe. Here is another case of Charcot-Marie-Tooth disease. She has got bilateral cavus foot. Her problem is that the right ankle gives way, and the right ankle gives way because of the varus deformity. So we have done here tendoachilles lengthening, calcaneal osteotomy, peroneus brevis to longus transfer, tibialis posterior has been transferred to anterolateral part of the foot, and there has been plantar fascia release. And this is the result. Her heel is neutral now, she can walk. She still has some residual deformity at the forefoot, but she doesn't complain of it. She had a non-healing ulcer at the base of fifth metatarsal, which has now healed. This is a guy with syringomalia. He has been dealt with plastic surgeons, and he has had 2 flaps put on, but his ulcer never heals. He came to me with an ulcer, and I treated the ulcer with a contact cast. So he has come out of contact cast after 3 months of plastering, and his ulcer has kind of closed. Okay. Now, you can't leave this foot. If you leave this foot, he will have ulcer back again. So you need to correct the deformity. This is after correction of the deformity. He comes out of the plaster, and this is him wearing normal shoes. The video is not playing, sorry, I'll come back to it. So these are the main deformities I wanted to show you. This is the video of this guy before his surgery. He walks on exactly on the area where the ulcer was. And that's the reason why he gets the ulcer in first place. The treatment of this is not the free flap. The treatment of this is to correct the deformity. This is him when he comes out of the plaster. This is a child. You see, he had an abscess drained from the leg, and he had a nerve injury secondary to that. See how he walks. All this is, he had a normal looking foot before, but all this is secondary. This is all iatrogenic. And this is him just before removal of his plaster. So in essence, you can correct these deformities without Ilizarov. However, doing it one-stage procedure, there is no margin of error. You need to absolutely understand what is wrong, where it is wrong, and you have to deal all of it in one go. There is no margin of error here. Thank you very much.
Thank you very much. Any queries may be addressed?
That is called the cosmetic orthopedics. I love to do the very interesting and difficult cases, and today I would like to share my experiences with the Ilizarov apparatus. So, cosmetic orthopedics is that branch of medical science which involves the anthropometric corrections of the deformity, surgical lengthening and reshaping, correction of congenital anomalies and gait, includes the application of Ilizarov technique, which is minimally invasive, aids in height increase by lengthening of long bones via Ilizarov fixator. It improves cosmesis and, of course, provides functional, mechanical, rehabilitation and psychological advantages. We are very happy in my country that we have the opportunity to showcase our talent. The Ilizarov technique is indeed like a mathematical formula. With its infinite variations, it can be used in many clinical settings, frequently when nothing else can be done. Its utility is limited only by our imagination, or rather by the lack of it. So this is, I showed you yesterday, it will be the biggest orthopedic center in the world. Within 3 years, 1,000 bedded. And next one, where you see this is the new version of that they have written after going to as a director. This is the Ilizarov Center, which is still the biggest one. And every year I'm going there. This is Ilizarov Center, you know. Everybody of you, once in a time, that is called the orthopedic Mecca. You can go there, you can see. So this is my picture. Everybody will be translated to the next world, today or tomorrow. But I'm lucky enough, among the foreigners, I'm the distinguished and visiting and honored professor of that institute. So why Ilizarov? I'm talking always like that. Indications you can see, I'm telling again, eye intelligent, L lengthening, eye infection, Z zigzag deformity, you can get angiogenesis, reliable, lot of opportunities, and of course versatile and victory. And 4 purposes of Ilizarov, yesterday I mentioned that one. Again you can see the problems here, dear friends, deform, again dysvascular, destroyed, totally you see, dislocation, gap, that is dysplastic, and this is the LLD. And look at this, a deformity could be of any extent. Look at this tree. And Ilizarov just like a hanging bridge. The tensioned wire holding the hanging bridge, a hanging bridge in wires working on the principle of tensioned wires. Even you can correct a deformed tree by Ilizarov technique. Look at this. If patients, you are orthopedic surgeon, patients come to you this situation with the parents. If in your hand the Ilizarov technique, you know it properly, at least you can do something with these difficult cases. So far I have seen no other options. With this, without Ilizarov technique, you cannot correct this type of severe deformities. Look at this, 7-year-old boy, post-osteomyelitis deformity, anterolateral bowing with 4 centimeter LLD. Here is the problems of 3 problems. Look at the deformity. You should have nothing to think about. If you have Ilizarov in your hand, just look what I have done. I have applied the 2 rings here, only the osteotomy of the fibula. After 4.5 months, I have done the destruction. That was the hypertrophic non-union. And you can see, next slide, only after 5 months. It's a good callus here, and deformity is fully corrected. Look at these 20-year-old female with CTV with post-polio residual deformity. The problems are ankle equinocavalvarus greater than 65 severe, LLD 3 centimeter, and external rotation of the tibia. You can correct this by Ilizarov. This is the result after 7 months. This is after 11 months. This is final radiograph, clinical appearance of the patient you can see. And now you can see after 11 months how patient is walking, 22-year-old girl. So I'd like to proceed later on. Look at this. The ankle is facing forward. No Ilizarov, no treatment of this kind. It's very difficult. Now this is final follow-up. Look at the picture, look at the X-ray. So this 39-year-old male came to me with several problems. 19 years infected non-union of the left femur with bullet injury. LLD 13 centimeter. Of course, He is not giving any support. That's why bones are osteoporotic. This was published in American Journal, 9th January in 2015. So look at this during treatment. 10 centimeter already corrected. And this is the final follow-up after 11 months with full 13 centimeter lengthening of the tibia as well as lengthening of the femur. So this is before and this is after. Yesterday I showed you this case. This was a challenging case. So you will get, after treatment, I showed you yesterday, you must know the quadriceps, how to do the quadriceps plasty, Judas quadriceps plasty with a stiff knee after treatment of the femur and tibia. Obviously you will get, in most of the cases, in the knee you will get a stiff knee. So, this is in the OT, nothing to be worried. It's a big incision, only blood, on 5 business operations. Look at this, only after 5 months. The patient is very happy and doctor is also happy. At least you can do something. So look at this hand knee gait with CTB, post-polio residual deformity. I'm sorry, the video is disturbing now. Look at this. She was walking like that. Now, after treatment, only after 9 months follow-up. Look at this. 18 years old female, CP, flexion contracture, FFD 90, adduction contracture of the both hip, bilateral ankle valgus. I have only treated this gradual distraction with minimally invasive of lengthening, of cutting of the semitendinosus and semimembranosus. This is after 7 months follow-up. Now we can see the height of the girl before and after 7 months. This is a difficult case with shortening with ankle valgus. We have lengthened the fibula and gradual correction of the ankle and foot, and this is the final picture you can see. And this was a case, the patient was taken to the OT for amputation of the elbow. The patient ran away from the OT and came to our center, and we have treated this patient. Gradually look at the elbow, unstable, full one, and skin condition was not good. Just we have taken the patient to the OT and we have fixed it with Ilizarov with hinges. And now you can see the patient can do the perineal hygiene also. So at least you can save, you can do something with this Ilizarov technique. And I would like to share my bitter experiences with this bilateral genovalgum with patellar tracking, 17 years old boy. Gradual correction, look at the picture, look at the x-ray. Now see, this is only, it took only 11 months. The gradual controlled coordinated stretching by Ilizarov technique, you can correct this kind of severe deformities. So this is another case. 12 years old girl came to me with her parents. She could not walk. The problems are, you see, 6 problems, and all are major problems. Hyperextension of the left knee, equinus of left ankle, flexion contracture of the left wrist, DDH of the right side, extension contracture, the right knee, severe equinocavalvarus, right ankle and foot. It was like that. With the support, she was standing like that. And we have done the soft tissue release, the left knee. Fisher-Curtis operation was done, followed by Ilizarov fixation. Second post after 2 weeks, after 5 months. This is the radiological view, gradual sequential. This is the PSO, in the right side we have done. And now look, she was walking like that. This is the NITOR, National Institute of Traumatology and Orthopedic Hospital in Dhaka. So let us see another case with bilateral genu-valgum with relapse CTB. For CTB, he was done 3 times surgery by an orthopedic surgeon, but he did not receive any kind of treatment for genu-valgum. Then, after 3 months, at the same time, I have corrected the genu-valgum. You can see, after 4 months, this is final follow-up, and this is how he was walking before. Now see how he is walking. So what you will do, dear friends? This is the scenario in my country. Look at these 13-year-old girl, severely open, contaminated, comminuted fracture, right tibia fibula, gastilo 3B with open fracture of the lower femur. Of course, you will go for amputation. This is the option. But when I was treating this patient, my junior colleagues in Nitor, they were smiling. What Dr. Bari is doing? He's mad. Then see, in your first day, 14 days after fixation, 21 days after fixation with Ilizarov, 28 days after fixation with Ilizarov, good granulation tissue is seen. After 2 months follow-up, after 2.5 months, this is after 7 months. You see, just like a live orthosis, live orthosis. This is after 7 months, just after the treatment, and I had a good contact with our family. Then they came to me after 3 years. Look at this picture. Patient is happy. Tibialization was done at that time. Now she is walking like that after 3 months. This is after 3 years follow-up. From that condition to this condition, and another case, look at this. Of course, you'll go for amputation. Gastilo 3B, 70 years old patient. Then I have fixed it, removed the whole segments, gradual transportation. Then see, 70 years old man, only after 8 months. So let us proceed fast. Again another dangerous case. See, I advised him also go for amputation. Family was crying. Then I told them, I can try. Then I tried my best. Just look at these, contaminated, infection everywhere. Femur and tibia is fractured. Then I fixed this Ilizarov in the tibia and femur. Always pus was coming. Then this is after 1.5 years. She came to me. She is a school teacher. Master's degree she has taken. And this is 1 year and 7 months. Now she came to me, like, look at this, after 1 year and 10 months follow-up. She is walking with crutches, not like that. And she is very happy. So dear friends, this is another case. I would like to share my experience with osteomyelitis radial clamp hand. Of course, no other good options except Ilizarov. You cannot do it because here, if you look at this side, the fibrosis tissue all tightened. Allah is bowed and hand is shortened. Then gradual destruction, deformity was corrected here. Then see, before, during and after. Look at this diabetic patient. And it was treated by an orthopedic surgeon. They told him, yes, you go for amputation of the 4th toe. Came to me in this situation. in this condition. Then I fixed it with Ilizarov. This is only after 2 months follow-up you see new vascularization. I have done the drilling with 1.8 millimeter K-wire here in this toe and fixed it. No skin grafting, nothing. And it was healed only within 2 months. The final result, yes. Now regarding complications, this is a fact. Complications are obvious in orthopedic surgery. Deformity and loss of function, no matter how slight in degree, may irritate or frustrate the patient. So we must give the best effort to minimize complications by giving meticulous, intelligent follow-up, a necessity when practicing Ilizarov. And in my conclusion, in cosmesis and deformity correction, excellence is achieved by correcting the correct deformity at the correct coda based on correct planning by the correct method to achieve the correct correction. Look at this. Yesterday I told you, you know these two, one gentleman, one gentle lady, for Burma, Suchi, and Professor Yunus from my country, Nobel laureate. They are fighting for the peace. Perfect endeavor around the countries of the earth. But I am fighting for the peace with these deformity patients. Never give up if you fail, because failure stands for first attempt in learning. And if you get no as an answer, remember no means next opportunity. And Ilizarov gives you the lot of opportunities, so always stay positive. Thank you so much. This is my private. Another picture, not that one. These are the Ilizarov patients in my country. We're treating not only in the leg, in the hand, in femur, in everywhere, from head to toes. But head I don't know, because I'm not practicing the head. In the Ilizarov Center, for CBD patients, they are using Ilizarov for vascularity of the brain. So, and these are the publications in American journals. Last year I published 14 papers, not this year, in American journal, different topics with TO, with leg lengthening, cubitus varus and valgus also. And my mentor, from whom I learned a lot of things. He is my mentor, my teacher, my good friend, and Professor Gubin, and I am giving my book to Dror Pale. So I would like to convey my best regards to all of them, those who have invited here. I am fantastically satisfied to see this hospital. And on behalf of Assami President India, Dr. Agarwal, I would like to invite you to come to Goa. I am also going there, Professor Shepsov coming there 22nd, 23rd and 24th January. It will be Ilizarov Conference, Assami, India. Thank you so much for your kind attention.
Thank you very much, sir, for that wonderful presentation. I now request Dr. Harshad Shah to hand over the memento and certificate to Dr. M.M. Bari.
By external fixation and internal fixation of fibula. It's not so good, but it's acceptable. Then they decided to proceed internal fixation. Okay, you see it's quite good. The joint is closed. You see the shape of the joint. They put a locked plate. Also the talus, it's not so well reduced, but case like this, it's acceptable. And let's see what happens. Now you can see that something's not going good. Okay, you see talus, you see fragmentation, and it starts to osteonecrosis process of the talus. But the fracture of the tibia heals. Okay, you can see slightly deformity here, but it's okay. But you have arthritis, you can't see at least the ankle joint, okay? The ankle joint has gone. There is no more cartilage, it has no function here. So, again, they proceeded arthrodesis by screws, okay? You can see the talus was removed because it was necrotic, okay? Quality of bone, you see it's not good, but they choose to do arthrodesis by this method. So what happened? The arthrodesis doesn't consolidate, okay? You see swelling of the foot, you see that something is not going well here, and we removed the screws. When we removed the screws, we see that there was infection, there was necrosis of proximal tibia, and also another part of the talus. So we have to remove almost all the talus and one fragment of tibia. Then we put this frame, the distal ring of the tibia, we have another proximal ring here, and in this case there is no talus, so we couldn't put wires on talus, we put wires only in calcaneum. You see here there is a half pin calcaneum because the quality of the bone was not so good, so we decided to put a half pin, put it under compression. We removed all infected, all necrotic bone. This is our frame. You see the half pin, 2 cross wires in calcaneum, 2 cross wires in forefoot, okay? And just compression and weight bearing. So you can see it starts to consolidate here and here. Here you see more bone, now you see bone formation, here, it's okay. No more necrotic aspect of the bone, no more infection. And believe me, in Brazil we have such things that we can manage. Here you can see again, it's consolidate. Okay, you can see this is very important, the shape of the foot. Okay, we learned that the foot must be a shape like a T. Okay, so this arm has been longer than normal axis. If you see, excuse me, when they did this arthrodesis, the foot is forward. So you can see this gap here, okay? This is not good for the patient with an arthrodesis to walk. You see this position is better, okay? We put the ankle, the tibia most forward, it means the foot backward. So this shape of the foot is better to walk. Here you can see consolidation. It's okay. And you see the patient took off the proximal ring by himself at home. Just like you arrive at home and take off your shoes, he took it. So we keep with this frame, with this situation for more 3 weeks, and we took off the frame. You see here, unfortunately, I have the clinical photos of after we put the frame, but when we remove the screws and do the cleaning of bone, we have a wound here, a very deep wound, but it was clean. There is no more infection, no more dead bone, so the wound heals only with the frame. The time we keep the frame, the wound heals. Okay, so here you can see, okay, the position of the foot. Here you can see it's quite slightly equinus, but it's relaxing. It's during anesthesia. The foot is mobile. You can see here fluoroscopy, when we remove the frame, it's consolidated. So in cases like this, the external fixation is the only thing we can do. Another case, you see not so bad ankle fracture, but not well treated. You see the fibula is not well treated, the medial malleolus, okay? So the patient came to us in this situation, okay? Exposure of distal fibula, tibia, malleolus exposed, a rigid equinus deformity, okay? So this is the x-ray. You see the malleolus, which was outside of skin. So what we can do in this situation? Only external fixation. So it's that what we did. We did a huge clean of this bone. We resected all this bone. You can see it's infected, it's necrotic, almost until here. We resected the distal fibula, and also the talus was compromised. You see here the talus, okay? It's necrotic. So we put this frame. This is the first case that I did foot correction and arthrodesis. In fact, it was my first bone transport. So I bring this case to you just to show that when you're beginning to do Ilizarov method, you have to be careful. You make mistakes. It's natural. You still learning. So I bring the mistakes I did in this case. So to do transport, I tried to put this kind of fixation proximal, okay? Also, we saw today, I believe that putting this half ring here, it could be better to the patient, flattening the knee, okay? We did this assemble to do transport, here to do correction of the foot, okay? When you're beginning, you believe that you are so powerful as the Ilizarov method, but it's not like this. You have to be calm. Okay, so this is our frame. We start correcting the foot. Okay, we start bone transport here. At that time, I was not so confident to do multifocal transport, so I do monofocal transport. So another mistake, you see the site of the osteotomy, it's so below, it's not at where it should be. It should be like here, okay? But we did transport. And you see atrophic regenerate. As we talked the first day, you have to be away from smoking patients. This patient was a smoker, so two aspects of here. I did the osteotomy below the preferential point, and also a smoker patient. So you see here, you can see already the foot. The foot's here, because it's so osteoporotic, and you see a huge gap here. So what I did in this case, I just prayed. I prayed every night just to heal and just keep going, okay? It heals, okay? You can see quite good regenerate here. I have to do bone graft at the regenerate site. I have to do bone graft, iliac graft on the docking side. It didn't consolidate with bone graft, so I put this, we call bioglass bone graft, and after this it heals, okay? So it's consolidate. You can see here, and you see in this case, I did not put the foot like I said before. You see it's shaped like an L, Okay, so this arm, it's not good for the patient walks. But in a case like this, maybe it's acceptable. You can see it's consolidated, it's integrated. It would be best to put the tibia here, okay? To integrate the tibia with this rest of the head of the talus and put tibia like this, okay? But a quite plantigrade foot, and you can see clinical outcome, okay? You see that patient at the beginning with that equinus deformity was not able to walk. He was not walking for 1 year, and now he walks quite well. Okay, you see? So the message is that you have to choose the right way to do your treatment. I would like to thank, because the message I bring, some years ago I was just learning, okay? I could, Questa Milano, sì. I have the opportunity to do my fellowship by one of the best Ilizarov surgeons in the world. And I still learning with them, I was still learning each day. I stay with brilliant people that brings me knowledge and inspiration. So as Professor Bari said, it's important, it's a difficult method, but we can learn, you can keep learning all your life, and you can do it very well. Thank you.
This is the last for today, so I don't stress you anymore. And a compliment to who resist until the end. So my conference basically was about the arthritis, septic arthritis. But we have seen many other topics on septic arthritis. So I put on a miscellanea potpourri of deformity for a pilon treated by external fixation. As you know, the pilon basically is 90 degrees with anatomical and mechanical axis. Now they changed, they said it's 89.7, but basically 90 degrees, and so you have to respect. So when you have a deformity, you have to define what is the plane of the deformity, if a frontal, lateral, or oblique, many times. And what is the core, center of rotation, or you can call cora, center of rotation and angulation is the same. And when you do correction by osteotomy, you have to do rotation around the center of rotation, perpendicular with the hinges perpendicular to the angle of the deformity. When you have a valgus or varus deformity in the ankle, you know that not only the foot is involved, you have a foot in valgus in pronation or supination, but the problem is the ankle. The ankle joint become arthritic very, very quickly. And so you can have valgus or varus, and the shear force are exactly opposed. When you have a valgus like this, sometimes the fibula open as well. The fibula is going out because the syndesmosis could could break it. Another deformity from the lateral plane is recurvatum, normal, or procurvatum. Usually, the angle, lateral angle is 10 degrees, 9 degrees respect the floor. And if the angle have a variation, you need to correct it if it's post-traumatic. When it's congenital, you have to watch carefully before to correct. Don't watch only the bone, but watch as well the subtalar joint. You watch the foot, because sometimes you have a procurvatum, recurvatum, varus, valgus in the bone, but the foot is plantigrade. And when the foot is plantigrade, means that there is a subtalar joint compensation. And when the patient doesn't have a problem walking like this, don't touch it. If you do correction in the bone, maybe you make alteration in a plantigrade foot, and the foot become pronation or supinated. So the degree, of course, of compensatory correction depends from the mobility of subtalar joint. If you have a subtalar joint stiff, of course you cannot correct. Now, when you have a simple frontal plane deformity, this is a very old picture I did 30 years ago. You see the line of the joint, the line of the mechanical or anatomical axis is the same. In a tibia, there is no difference. And the cross line is here. What means? Means that the deformity is articular. Is not proximal, not distal. It is exactly at the level of the joint. What you do? You do one osteotomy where you want, of course, closer the joint than possible. But the hinges have to be exactly in the point of rotation. So when you do correction, you achieve this kind of rotation translation. Basically, translation is subsequent of the rotation. It's like an open, close wedge at the same time. If you don't do this, like sometimes some people, the beginners, they apply hinges at the level of the osteotomy, and they do the osteotomy, and the joint become flat, 0 degrees with the foot, with the ground. But you see there is a translation, it's okay? And so to avoid this translation, you have to put the hinges exactly in the point of the deformity. Look at this. These are 3 different valgus, valgus, valgus deformity. But if you measure well, one deformity is here, the center of the deformity is here, and another one at the center of the deformity is here, another one, the center of the deformity is here. So this is the trouble. You have always to watch carefully the deformity. It's the same in this case. The center of the deformity is here, is a varus. Center of the deformity is here, is a varus. Same. If you don't observe, maybe you don't understand well. So it's so important to do it. This is a case of varus deformity. The hinges have to be here, and the correction, of course, around this point. Why around this point? Because if you apply in this point, you cannot achieve correction because you impinge, and so you have to stay away from the fibula. You cut the fibula, you cut the tibia, and you stay in a line. This line that I didn't draw is a bisector of the deformity. So the deformity is here, the line is here, so any line is good for correction of the hinges. We introduced about 28 years ago these hinges, we call just articular hinges. So the advantage is that you can apply very distant, and it's very stable because it's on the ring. We use other different trick to have just articular hinges, but this is very simple and tricky. So in the case of varus deformity, you see we apply hinges here, we do distraction simple, and you translate everything. And if you watch the joint like this, the joint is absolutely normal, okay? Don't care about the deformity, the little deformity. because when you do translation correction, you achieve as well a perfect alignment in the joint. This is another case of valgus they show. This is a deformity here, so the point of the correction is here, laterally, and so you achieve lengthening and correction of deformity. If you don't want to have a lengthening because the leg is not is normal, you apply your hinges more in this position, or it's much better you do first correction and after you do compression. One trick when you do lengthening, any lengthening, is to do a little over lengthening, wait for 10 days or 20 days, and after doing a little compression. So you compress the new bone and your bone healed quickly. Procurvatum deformity is the same. You see, when you have a procurvatum, you have the center of the axis is not in the center of the subtalar joint, it's anterior. So you have a translation as well of the loading force. And when you have a recurvatum, your center of the loading is back, and so it's not exactly in the center of the subtalar joint. So when you do correction, you have to consider to keep this line, the red line, and to become parallel to this. And so this is a deformity, this is a bisector, this is a point where you have to apply hinges. And so you correct and translate a little posterior. And so the axis become perfect, aligned. It's the same when you do correction for procurvatum. You do hinges in this position, correction, and translation. And so the line become, the two lines become, are in the same line, the two segments of the line. So do you understand? This is not so difficult. Not always the deformity is so easy when you have a pilum, because not always you have a tibia. Sometimes you have tibia, fibula, grow arrest, and so it's a complex deformity. This is a complex deformity after partial epiphysiodesis. But this is a patient, what you do in this patient, you cannot do you cannot open the grow plate. And the solution is to consider this like a deformity, stable deformity, and doing correction of the angle, lateral angle, frontal angle, and you see the fibula is lower than normal because the fibula was not involved in the deformity. So what you have to do is deformity correction and pulling down the tibia at the level of the fibula, at the level of the joint. And you see there is a osteotomy of the tibia here, osteotomy of the fibula, osteotomy of the tibia. We move down, and the lateral malleus went spontaneously in a good position because we fix the malleolus with one pin. So we did a kind of differential lengthening, not the same lengthening in the tibia than in the fibula. So we pull up the fibula in this patient. This is during the treatment, the frame on, the original Ilizarov, and the end of lengthening. You see the fibula is about 3 centimeters, and the tibia is about 4.5 centimeters. So it means we did differential lengthening to put the joint more physiologic than possible. And this is a final result. What you see here, I didn't show before because it was under the ring. Before to do this correction, you have to be sure that the deformity remained the same. And so you have to stop the growing of the tibia, drilling and applying staple. We use this small staple, it's a titanium staple with a simple machine 3M, tac, tac, it's 5 seconds. This 1 year follow-up, 2 centimeters of discrepancy, no deformity. And this ankle, a little motion, was stiff before, stiff later. This is a follow-up, not bad, and we did just a final lengthening and maturity. And this is a case. This is another case, similar, post-traumatic deformity, but if you do correction in this patient, what happened? That this deformity continues because the patient have a grow arrest in this side, and the fibula and tibia in this side is continuous growing. And so it's mandatory to do fusion. So you do fusion here, you do fusion here. It's a simple, just a small incision, you drill and you apply staple. And the fibula is staple in the tibia. And so you avoid any overgrowing. And you do correction, lengthening, as you know, and this is the final result. The joint is not bad, and you see that now the tibia and fibula doesn't grow anymore. So remain like this, because we did a fusion. I don't have we did a hyper-lengthening, a little bit of hyper-lengthening, about 3 centimeters of hyper-lengthening. Now, I don't have the final. I don't know where it is, somewhere. This is a post-traumatic, almost the same. You see grow rest here, that the fibula is overgrowing. If you do osteotomy correct, the deformity come back. And so always fix the fibula to avoid any recurrence. The hinge, just articular hinges, and you see correction, translation. And this is the final result. The joint is now parallel. You see that we fuse here, we fuse here, we fuse here. So now there is no more risk of recurrence of the deformity. Over lengthening, we did a 12 millimeter in this patient, and no more discrepancy, 4-year follow-up. This is, sorry, this is the other patient that I showed before. The slide escaped. Did you understand? Now, one case like this with a very comminuted fracture, what you can do, I don't know if you have a pediatric here, but this is not, you cannot open, this is a very bad fracture. Probably the only solution is to apply traction or maybe any monolateral external fixation, because there is any risk to open. But anyway, this patient was treated by plaster, and this was a final result, grow rest and deformity. You see as well the fibula, where is the fibula is pulling down the talus and the calcaneus. As well in this case, we did a differential lengthening of the fibula. The fibula was locked, and tibial lengthening, correction of deformity, fusion, distal fusion. This is during the treatment, sorry, of the x-ray. This is during the treatment and lengthening, and this is a final result. It's not so bad. If you think from where we start, this is really a good result. Of course, tibia, the growth plate, doesn't exist anymore. And this is a radiological 1-year follow-up, not bad. 2-year follow-up, discrepancy about 3 centimeters, and the final lengthening of the patient. It is a final, no more discrepancy after removal of the frame. As I told you, the deformity is important to correct. The lengthening is not so mandatory. You can use a show lift and no more problem. This is another deformity, it's an adult patient, 2 deformity, procurvatum and varus. But there really is not 2 deformities, 1 deformity in oblique plane. So this is during the operation, the x-ray with the osteotomy. This was done with the multiple drill osteotomy, frame on, and you see the hinges. Your articular hinges are in oblique plane. This is a prototype of one of the prototypes that we still using. So we correct simultaneous varus and procurvatum, okay? And you see that we fix the foot. Why we fix the foot? Because the foot was good position and the subtalar joint was in a good position. If you do correction sometime, in this case, the subtalar joint moves. And so maybe you don't understand exactly correction. So it's better. Finish correction of the bone and after remove the pin to understand if everything is good. This is a final result. This is a good shape, a good function of the foot, of the ankle. And this is X-ray at the end. You see correction on frontal plane and correction of the lateral plane. Looks a little bit deformed, but now is no more procurvatum. Is a good. This is another case with a similar deformity, but this is pathologic for multiple exostosis, is a recurvatum and valgus. In this case, we did this correction, and this is the final result with a good axis, mechanical axis is good, and lateral axis is good. Now, we watch some deformity a little bit more complicated. This is a fracture treated with a plate, very old kind of plate. And the patient developed after infection of the plate was removal, and after removal of the plate, infection disappeared. Because remember, the plate is like a foreign body. If you leave it, the infection increases. If you remove 80% or 90% of the case, the infection disappears. So this is a non-union with a deformity, angulation, valgus, and recurvatum on the posterior bowing. As you know this system, this is a system to calculate how many degrees is the deformity. It's very simple. There is a medial translation, is a 2.5 centimeter, 25 degrees of varus, and 20 degrees of procurvatum. So you draw the line. This is a bone, this is soft tissues, this could be the ring. Okay, is a simple drawing. 2.5 centimeter correspond to 25 degrees. 2 centimeter correspond to 20 degrees. And you measure this from 0 to A is 3.2 centimeter, means the deformity is 32 degrees. Basically, you can have a 3% of mistake. And so you draw the line perpendicular to the deformity, and this is a point of application of the hinges. So basically is easy. This is not my idea. This is the idea of Ilizarov. Ilizarov teach to me. I didn't understand the first time. Probably you didn't understand the time. But anyway, this Ilizarov teach to us this kind of correction. You see the hinges, very strong hinges, this progressive distraction, and this is a frame construct with the hinges very strong, and this is a correction, new bone formation. This was a true hypertrophic, very stiff. The patient was almost walking without pain. So when it is not so hypertrophic, it's better to do open surgery and graft it. In this case, we did just correction, and we correct the deformity of the foot. And this is other deformity, same hinges at the level of the deformity, correction, fusion of the fibula, tibia is not much growing, fusion of the fibula, and correction of the axis. Easy with the oblique hinges, the function of the hip. This case, you know, deformity of the ankle, or deformity of the foot, but basically it's deformity of the ankle, is hemimelia. Do you remember the case? But I show again how much is the translation rotation, because we did the osteotomy at this level. Probably you can do the osteotomy more distal. More you stay close to the joint, less translation you have. And this is a final result. Ankle arthritis. This is a simple ankle arthritis. The patient complained for a lot of pain, a lot of pain, a lot of pain. So we decide to do fusion of the ankle. And when I do fusion, I remove talus, I remove the chopard, I remove the lateral, the medial malleus, and I remove the fibula. Minimum 10 centimeters of fibula. Why? Because for two reasons. First, because the fibula, you don't need anymore the fibula for fusion. And a second, because aesthetically, when you do fusion with the fibula, the ankle become swelled, big. The shape is not so good. If you remove the fibula totally, the shape of the ankle become good. So this basically is a scheme. This is a lateral view. Why I show this? Because I don't put the tibia at the level of the subtalar, the sinus tarsus as usual. Because if you put this, your foot becomes like an L foot. L means long anterior and short posterior. So when you translate a little bit anterior, couple of centimeters, 1 or 2 centimeters, the tibia in the foot, you achieve the T-reverse foot. It is a case, you see what is the synostarsi, you see what is the tibia. It's anterior about 12, 15 millimeter. This is a frame on. I don't apply any wire in a talus. I just do only foot fixation, very stable, 3 wire anterior, 1 wire, 2.5 pin posterior, and this is the final result. You see the joint, this is a callus here, and the axis is anterior and the synostarsis about 1.5 centimeter. And this is so-called T-reverse, and aesthetically is much better. You see aesthetically, and the patient is walking better because the anterior foot is shorter, so she doesn't need to move the knee too much. Now we go in the post-traumatic arthritis. What do you do in this case? It was post-traumatic arthritis infected. I forgot, sorry, this is Italian. Post-traumatic arthritis infected. What you do in one case like this? You try to do fusion, you try to do nothing. You see, this was other external fixation. It was an orthofix, apply few years anterior. So one case like this, the only solution is to remove all the dead bone. This is a kind of necrotic bone. It's not available bone. So you see, we remove the fibula, this is a joint. What is the cartilage? Well, probably only this piece is a piece of cartilage. You remove everything from, in this case, we remove all from lateral side. Only one incision. Sometimes you have to do one incision lateral and one median. This is similar we use to insert a couple of K-wire. This is compression progressive. When it's infected, I don't like to do acute compression because it's better to leave open, a little bit open the wound so everything is coming out and the infection disappears. In this case, we did a 2-level osteotomy like the other patient that he showed my colleague. This is a frame on, 3-wire anterior, 2-pin posterior, very stable. And this is the final result of the patient. A little swelled, but more than this, what you can do. So consideration, you need, for when you use Ilizarov, a meticulous plane to do this. But, and you have to study, you have to apply hinges in the right position. Now, with the hexapod, is much better. And so I show one case, only one or couple of cases with hexapod. You see, this is a patient with multiple deformities, second-degree semimia, recurvatum, and is, because this is not in a good alignment, non-union of the tibia. He had the lengthening with the orthofix before. And deformity in the foot. This is a ball and socket joint, and so it's unstable. You can correct this at the level of the joint. And we applied two hexapod. As well, we did a correction of the femur, I didn't show. But anyway, this is 1, 2, 3 osteotomy, this patient, simultaneous correction. So with the TSF, you don't need to study too much. You have to apply this ring perpendicular to the bone. And the other ring distal as you want. Usually I apply perpendicular to the foot. And you see correction proximal. We did a correction, this is at the time of the osteotomy, and this is osteotomy distal, very distal to correct the foot fixation, because in this patient, always is better to fix the foot until you finish correction. And this is a final result. After correction, you see a little bit of translation, and it's a correction here, lateral, and we correct the procurvatum just a few degrees. We did a 1.5, 1.8 centimeter of lengthening. And the varus is varus like the other leg. So with the TSF, now is much better to do correction. Thank you for your attention. But it's not finished. You have to tolerate me again. Few moments. I want to present now the last conference is a new one. We presented this in Miami. Was published about 3 months ago. Was an experience by me and friend of mine from Milano about the fusion of the elbow for arthritis, for post-traumatic. And so just to show this, just to show how we can do. The elbow orthodesis is rarely performed, but now you have to consider that some people become crazy with the elbow prosthesis. And so when the patient have a little bit of pain or something, no good motion, tack, elbow prosthesis. Elbow prosthesis means high risk of loosening and much more infection, elbow prosthesis. So pay attention when you decide to do, send to your friend, much better. The ulnohumeral arthrodesis sometimes is difficult because the peculiar bony anatomy around the elbow, but this is not really so true. Radioulnar arthrodesis is more difficult. This is more difficult because the whole ulna is big, the radius is small, proximal, but when you don't have any more ulna, you have to do this. And overall, it's more challenging when you don't have a bone stock, because with a elbow prosthesis, you cut the bone. Every elbow replacement is a kind of destroying bone. When you do elbow arthrodesis, we prefer always, if it's possible, to apply bone graft around the joint without external fixation. Why without external fixation? Because this patient came from a long way of infected elbow, maybe 1 time, 2 times, 3 times, because doing a mistake is human. Repeat the mistake is diabolic. But anyway, many devils around. And in this series, we show just only 4 patients, but in the literature, not so many of these with external fixation. We present how we can do. In 89, I've seen this publication, 89, very early. I never seen until I decided to publish my topics. And I've seen this from French and from Belgium. 89, published this, and probably this patient was done 2 years earlier. So it's very early Ilizarov system in Europe by this author. And this was an arthrodesis with a simple original Ilizarov. You see only K-wire. The only problem is 90 degrees, but anyway, this was the first one that we found. This other kind of arthrodesis, you see the fracture, this was published 2008, fracture, good fixation, plate broken, another plate, removal, infection, external fixation, beads, you see beads, and after clean fixation, and finally, because a non-union, somebody applied, the author applied fibula graft, not vascularized fibula graft. Anyway, the patient arrived at the consolidation at the end. So this is a method, one method with external fixation. Usually, many other authors, they prefer to apply plate, so internal fixation, but not always the plate is going well. Like in this case, you see the infected non-union, plated, you see the plate, and after terrible infection, the plate was removed. I don't have the D, because this published, and the author said we remove for infection, full stop. I don't know what happened. This was done in 2014, it's a recent. So the plate has some risk. We do our construct with a wire and a half pin. Basically, I use almost all wire except the distal wire maybe in a humerus, but I prefer to have a half pin, easy. And the advantage to have circular fixator respect the monolateral, that the circular fixator, you can arrange the elbow flexion. So now I show our case. I don't want to stress you. Case 1, 75-year-old was injury in the right elbow, radial head, coronoid fracture, multiple surgery procedure, internal fixation, primary total elbow, second revision, allograft, and another total elbow. She had 2 times total elbow. So it's a very terrible story. This is not a terrible fracture like they say. You can fix well if you open. If you are a good surgeon, you can fix well. But unfortunately, she remained like this. So the surgeon decided to apply prosthesis. So first total elbow prosthesis replacement. And you see infection, loosening, loosening, plate and infection, removal, external fixation. Apply this external fixation for movement of the injury. Another prosthesis, another plate for another fracture. So you understand it's very, very terrible. So when this is a patient of my friend from Milano, when he opened, he found this kind of bone, a necrotic bone as well. So this is frame applied. So it's a custom-made frame. It's just 2 rings and 2 arches, and about 4 half-pin proximally, 2 or 3 half-pin distal. It's very simple, and put in compression, under compression. In this case, was not applied bone graft because it was infected, and this is the final result with the function 90, about 100 degrees of extension. I prefer to leave a little bit more personally. The case 2, another case involved motorcycle accident, and so he had radial and ulnar bone defect and multiple debridement, antibiotics immobilization with external fixation, in different hospital. And he was not possible, he didn't get consolidation. And so was decided to do this. This is a patient treated, I don't know where, around Rome. And this fracture, this external fixation. The idea is not bad. It's not bad. It's to do fusion. But how you can get fusion with this kind of bone? The bone is maybe is a bone, cartilage, and bone, and so there is no possibility to consolidate it. So this is a patient of mine. I just open, remove a piece of bone, not good, put together temporary K-wire, simple external fixation like this, and we get consolidation 3 months. So when you have this patient, open is not difficult to open. You open from posterior or from lateral, and you graft it. Bone graft is much better always. This is another case, comminuted fracture. You watch the date, January 12. External fixation, temporary, 2 plate, but think how much you have to open the joint, how much you have to devitalize the bone with the 2 plate. Anyway, 2 plate, fracture of the plate, another plate, and fracture, rupture of the plate is about 2 years later. So the patient remained 2 years under treatment. Removal, everything, and was applied this frame for correction of deformity and extended to the ulna. This frame on, and my friend tried to bend the joint, with this kind of hinges, but fortunately, the nature provide a fusion here. And so it was fused, but the non-union consolidate. So fusion and non-union consolidate. Here remain with this range of motion 0, but it's good. Case 4, this is my case. This case was treated as a hardball smoker, drug, everything, drinkers overall, drinker and smoker. And he had post-traumatic trauma, and after many operations, he had prosthesis. And we removed prosthesis. I don't have a picture of the prosthesis. We removed the prosthesis, and because a big gap here, it was infected, we did a transport. You see, proximal fixation, medial fixation, distal fixation, very stable. Oh, sorry, I don't have I forgot, I lost, sorry, I lost the slide, but I can tell you the story. This patient went to the transport. He developed, because hard smoker, atrophic non-union here. So we did many times compression distraction until we arrive at the end of the contact, but the patient developed infection again here. And so we remove everything. We say, you wait a little. We do another time. The patient said, I don't want to have anything. He went home and I don't know, he suicide somewhere. So I don't have a final result. But the new bone formation here was on the way of consolidation, but distal was really infected. So this was a failure of the transport. And in terms of function, in a fusion, what is the function of the elbow? The elbow is 0 flexion extension, but when you do fusion of the ulna, you have a pronosupination because the radius is rotating around the ulna. So pronosupination is good. When you do fusion of the radial head with the humerus, of course, you don't have any possibility. So in conclusion, when you don't know what to do, when you have infected elbow, you have an infected plate in the elbow, you have to reset that bone, you have infected prosthesis, the only solution is to do fusion. And why fusion with external fixation? In my opinion, because external fixation is in my mind and my soul, but as well because you avoid the risk of internal fixation of infection. Because when you apply a plate, the high risk of infection, you have a 30% of risk of infection. I show you the case. So this is my conclusion. So if you need to do total elbow replacement before to do it, think at this complication. And this is my friend from Milano, and this is me last 2 months ago. Thank you very much. I would like to take
Sir.
Over to Dr. Kirienko on his topic, salvage of failed ankle arthroplasty by limb lengthening.
Good afternoon, everybody. I try. Okay, now it's working. I try to do my presentation a little bit faster because material is big, and I do it a little bit quickly. Okay, and I will talk about arthroplasty. Ankle arthroplasty nowadays became really popular, like elbow arthrodesis, that Maurizio. And the indication for arthroplasty should be chosen really good because there is many complication, and many articles published about this, and the rate of complication of this kind of treatment is 44%, and some works. Big job. And survival of the total ankle prosthesis is 0.64% after 10 years. And result of this failed, it is ankle arthrodesis. And the simple situation when we talk about ankle arthrodesis, it's maybe simple enough surgery, like here in post-traumatic cases, like we see the previous authors demonstrate us, but it's became much difficult when we have failure of total ankle replacement. Because after total ankle replacement like this, when it is a failure and unstable and painful, removing the total ankle arthrodesis, it means to do the leg shorter. In this situation, we need to apply the frame for arthrodesis, and we need to do the lengthening. In this situation, when we go to remove the ankle replacement, we should do lateral approach, or now there is some prostheses that do it from anterior approach, and some prostheses do it laterally. But majority of the case, we need to do anterior approach to remove the prosthesis, and I show you some clinical case how it will be done. This is a patient that have failure ankle replacement, painful ankle, unstable, and when we go to remove this prosthesis, it will be destroyed. The distal part of the tibia, we should remove big part of the anterior talus, proximal talus, and like you see, it's formed a big defect of the distal tibia and the talus. You see shortening. If it is possible, we do it acutely because it's better to achieve a good contact immediately, and later on it will be done. The same surgery we do osteotomy of proximal tibia and the progressive lengthening. We achieve the ankle arthrodesis and the lengthening and the proximal part of the tibia. Another clinical case, it's failure of total ankle replacement. The patient was operated again with a retrograde nail. That surgery, I don't like it too because it's really traumatic surgery because it's destroyed the subtalar joint. Sometimes it's better to save it. And here they put the allograft with the femoral heat. The patient always have a pain, and it was necessary to do revision. We removed the nail, the retrograde nail from the calcaneus, and it was done arthrodesis and the progressive lengthening of the tibia. In this situation, it was not possible to do it immediately. Like you see, it's remaining a little bit gap, and we do it progressive compression for achieving arthrodesis and progressive lengthening of the proximal part of the tibia. And we achieve the lengthening and arthrodesis. In this case, the patient, like you see, he loses completely his talus, and we achieve arthrodesis between the distal tibia and the calcaneus. This is his clinical view after 2 months after removing the frame. Another situation when we should do arthrodesis, in my practice, I find, because if you know, there was this published, and there is a series of the patient was operated in Italy for allograft of the ankle. This is one of the X-ray of one of the patient. It was done surgery, like you see here. This is allograft with the cortex, subcondylar cortex, and the condyle for the distal tibia, and the proximal part of the talus. This surgery was done. It looks really good, but after 1 year and a half, the situation is like this because it was failed and they completely destroyed. And another bad thing that, like you see, allograft continue destroying the proximal talus. After removing the allograft, the situation like this. This is allograft bone, and this is bone we removed for clean. And we did arthrodesis, and we did gain the length of this leg. And this is a result after 3 months. And this is a result of 6 months. Another clinical case with allograft, the similar situation here again. You see the failure of allograft and how the talus bone is consumed after this surgery, because allograft probably provoke reabsorption of a rounding bone. And this patient was done a lateral approach. We should to remove all the bone from the tibia and the fibula. Again, like you see, this is allograft, completely dead bone, and probably this dead bone produced the absorption around the healthy bone. This is lateral approach, arthrodesis of the ankle joint, and we achieved good arthrodesis. And you see it remained just a little bit of valgus, but the patient was really happy. Function remains good, and he walks and he may run with the ankle arthrodesis good enough. In the case of the infection, it's a more difficult disease, and this situation we should do bifocal osteosynthesis. It means we should create a defect because it's become out of shoulder we do, and the progressive lengthening of the proximal side of the tibia. Like in this case, this is post-traumatic septic arthritis. You see a really big fragment of the distal tibia and the fibula. It is completely destroyed, like a big sequestrum, dead bone. And we remove this. Yes, it remains big defect of the distal tibia. Progressive lengthening of the proximal tibia. A big amount of lengthening, quite 8 centimeters here. And compression in the site of arthrodesis. We achieve this arthrodesis 2 months after the result after 3 years, and this clinical result after 10 years. The patient stay always good, and he comes to me for not for the control, but he comes because one of his parents should be visited, and I did the picture of his leg. Another clinical case, really young boy. He comes from Romania, 16 years old, traumatic open dislocation of the ankle. It was done really simple, mini invasive, like they said, osteothesis of the ankle joint, but after 3 months, you see it's really bad septic arthritis, and the arthritis was so important that the drainages was quite 200 millimeters of pus each day, and like you see, arthritis destroyed completely not only the joint, but the proximal part of the talus. And this is his situation. When we took him in operation room, we did a bilateral approach. It is lateral approach, like you see, it was really dirty bone here inside, many dead bone. I should clean everything from distal tibia and the talus. And again, I did the medial approach for cleaning medial malleolus, because the fistula, when it was drainage, was in the medial side. And after that, we did shortening, acute shortening. This is that bone we find there. We corrected the deformity, and like you see, we tried to save the posterior subtalar joint, to preserve the movement of subtalar joint. We did the immediate compression, proximal lengthening. This situation, he healed it really good. No more drainages from the fistulas, and he started walking good, and the healing was done in 5 months comprehensively with a good radiological result. Like you see, it's healed really quickly and fast, and this is his clinical result, clinical view, and walking. It's quite normal in this situation with ankle joint. The patient may walk in good enough. And here goes in corridor 2, walks quite completely normal. And he runs too. Another clinical case is infection. It's post-traumatic chronic osteomyelitis. Here was involved a distal tibia and the proximal part of the talus. We remove all the dead bone. Simultaneously, we apply the plane of the tibia, like in previous cases. And here, again, you see amount of shortening we should do for achieving the good contact between the distal talus and proximal talus and distal tibia. During the treatment, patient may walk because he uses special shoes. He likes this kind of shoes. He give me this video. He do it at home. That he may do the stairs with the frame. His dog accompanied him always for treatment. And this is clinical result of this patient. And like you see radiologically, we did the contact between the distal tibia and the calcaneus. And he healed it in this way. Another clinical case with the infection, post-traumatic infection, the patient joined us in this situation with external fixator, but it was really bad necrosis of the distal tibia. Like you see dead bone penetrated with the wires. They keep it for a few months. It's a strange situation because the patient comes to me, but the doctors who treat him never wants to change the plan, the treatment. Keep it in this wound. When I open it, I should remove necrotic bone. It was many pieces of necrotic bone inside. And only one advantage in this situation, when we remove too much bone, I should achieve good contact of the skin. This is amount of bone we remove there. And I should close the wound on the level of the ankle joint. We applied the frame, and we did osteotomy of proximal tibia simultaneously. This is the first control. The wound was really clean, no more infection, and we achieved proximal lengthening. This is the wound healed completely, and this is the radiological result of the ankle joint arthrodesis, and this is his functional result. The patient walks good enough. He uses special shoes, really soft shoes for walking in this situation. Another clinical case, it is one of I want to show you because it's like a candidate for arthrodesis. The anesthesiologist works in a humanities hospital. He arrived. This is what my first patient in humanities. He arrived in this situation, was done this osteosynthesis because of the soft tissue lesion. It was only temporary fixation, and we thinking about arthrodesis. But in this situation, we realign the bone, and we do the proximal lengthening lately, and the skin survived. Like you see, it was really bad scars, but there was no more wounds. We fixed the foot for maintaining the good position. Another thing that he have a fracture of the femur. He have a fracture of the elbow and the ulna, and he don't want to treat them differently. And then the external fixator, and later when we do frame of the femur for the pseudoarthrosis and the frame of the radius for the treatment of pseudoarthrosis. But in all this frame, he permits her to go to job and permits to do her job like an anesthesiologist. Another clinical case, the last one, it is post-traumatic osteomyelitis distal tibia with articular involvement. Because if you look the CT scan, it looks not so bad. There is here big cavity. It's like a hole in the distal tibia, and this fistula maintained for a few months. But the problem of this joint was articular involvement. But like you see, the fistula goes not only in the distal tibia, but it was penetration on the articular surface. Meanwhile, the talus was good enough, good shape. And we did again medial approach, and I should remove all this necrotic bone with the cavity there. And I couldn't save, unfortunately, the articular surface of the tibia. This is articular surface of the distal tibia. Like you see here, it was a hole that penetrated inside of the joint. But after we did the lengthening, we did the arthrodesis of the tibial talus arthrodesis, only separated and proximal lengthening. This is the result after removing the frame, and this is again result after 6 months. And this is clinical result of the patient, how he walks without shoes. And the important thing that I want to notice, if you conserve the movement of subtalar joint, like in this case, you see how good the movement of the foot. It looks like it moves ankle joint, but it is only movement of the subtalar joint and the shopper joint. Altogether, they produce really good function. And like you see, the patient may move an abduction, pronation, or supination, because we conserve the movement of subtalar and shopper joint. And the same here when he is bed, like you see, he moves, he do pronation and supination of the forefoot and abduction of forefoot. And how he walks with the normal shoes, absolutely normal shoes, without any problems. And sometimes I ask it, he might run some small distance. Okay, and thank you very much for your attention.
Head of the department to hand over the memento and certificate to Dr. Alexander Kirienko.
Thank you very much. Thank you very much for your attention. Thank you. Okay. Appreciate it. Thank you.
Over to Dr. Alexander Gubin for the topic Applications of Ilizarov in Spine Surgery.
Okay, do you know this coaster, this boat? It's, you see, Costa Concordia. You know that people may be happy if they have a safe boat or if they have a parachute. And in spine surgery, ideas of Ilizarov are like a parachute procedure or like a safe boat, because as we used to say, if you are going by a big coaster, a big beautiful boat, it's a big privilege to have a safe boat. And in spine surgery, ideas of Ilizarov are like this safe boat. So what we can really use Ilizarov in spine surgery? Yes, we can. First of all, we can use external fixation as a research tool, because it can be used as a measure tool, and it's very convenient to use it as a measure tool. And we use compression destruction systems to study different kinds of fusions, different kinds of allografts. I do this when I was a postgraduate, and it was my candidate dissertation. And you see this Russian patent on this model, and this model of allograft and fusion using this very simple external device on the rat's tail. But what's in real life? In real life, we have two types of external fixation for spine surgery. First type is real transpedicular fixator. We have our own design of this very simple system for transpedicular fixation on spine. This is all instruments you need. You need C-arm to apply the system. And this is an example. How to treat multi-plane deformity using external fixation. But what is more important, we need right indications when we really need control, when we really need to elongate the period of distraction, the period of correction. These indications are high-risk spine surgery. You see this girl with neurofibromatosis signs. There is a big neurofibroma in her spinal channel. So it's very dangerous. Even if you use electromonitoring, neuromonitoring during surgery, it's very, very dangerous to make any procedures on her spine, but she has very huge deformity. So to obtain safe treatment for such kind of risky patients, you can use this method of applying this X-fix, transpedicular real X-fix, and do very slowly, but not further, no longer than 1 week traction, derotation, after real clinical control. So you can look at this patient, look at her extremities, look at her neurological status, understand that everything is absolutely fine, and she doesn't have any neurological conflict and never neurocirculation conflict. Because sometimes, if you even have very good neuro monitoring system, you can get, in such cases, in a very bad conflict of blood supply of spine. Traction problems, spasm of arteria, and absolutely paraplegic. So we can use this system and quickly, after 1 week, maximum 2 weeks, replace it to internal fixation. Yeah, as usually, now it's a new protocol. For such cases, we need very quick replacement. So 2 weeks for us is maximum, because after 2 weeks, pin site infection will be in a high risk. So, and we use the same sites for our screws. So anyway, 2 weeks is maximum, better 1 week, 10 days. Another case, you see, so very, very bad deformity with, again, high risk of neurological deficit and bad bone quality. So we put this system, and then we made anterior approach. Sometimes we make it open, sometimes laparoscopic, just to really create osteotomies, because in these situations, the spine is very rigid. It's like bone, really. So you need very good osteotomies, but it's very dangerous to make one moment, one stage restoration after such osteotomies. So you can apply again the system, and this is a real Ilizarov approach, because you are making osteotomies and then step by step restoration of the deformity. And then again in 1 week, maximum 10 days, you are going to restore this huge deformity, make it half, and stabilize it with internal fixation. Spondylolisthesis is another big problem. We usually have problems of fracture of our screws in spondylolisthesis, especially high-grade spondylolisthesis. And some situations are very painful. You see that here is near to spondyloptosis situation, and very painful, and in high neurological risk. So you can use step by step, but again in 1 to 2 weeks reduction by external fixation. And then you can go to internal fixation, and of course you are going to leave from posterior or from anterior, which is now more rare, to make very good fusion, anterior fusion. Hollow. Hollow fixation is widespread and well known, but not everyone can use it. Some people really refuse to use it. Some don't know how to do this. But it is very, very simple and very, very effective technology. You can use Ilizarov frame, original Ilizarov frame, to create any kind of hollow fixation. So it's traditional, you see, Ilizarov frame, pelvic part, hollow part. This we published in 2 years ago in Global Spine Journal. You see this Allier disease and very huge deformity of neck. And unfortunately, this guy, he got to emergency because of breath problems after such a huge deformity. So in emergency, we put hollow frame. It's like a parachute procedure again in this case, yeah. And we improve the position of his head. After this, he began to breathe well. So he began to move. And so in these cases, we don't need to be very fast with replacement of our frame to internal fixation, because we don't have any risk of pin track infection in spine. So in this case, We were waiting for 1 month after his full stabilization, and he was ready for big surgery. And then we go to this system, to neck and thoracal fixation. This is hollow cast system, when you can use cast and hollow. This is another my patent made of, you see that it's a bicycle tube, very simple, and hollow traction, and Ilizarov rods. This is bicycle tube and hollow traction. You know that when we distract neck, it's a problem of sagittal balance in neck, because we usually make neck very straight. And if you want to make, yeah, I will tell. Oh, thank you. And if you want to make sagittal profile lordosis, to restore lordosis in neck, it's a very simple solution. You can put the balloon here and make good restoration of sagittal balance. What's more, in some dislocations, you can put this pressure, balloon pressure, on the vertebra and put it into the sagittal line frontally to obtain sagittal balance. It's a very simple, cheap system which were made by handmade, and we used it for many cases. In dislocations when you need traction, especially in pediatric population. Unfortunately, it doesn't work. Okay. Another kind of traction and fixation using Gala. You know, it's Atlanta axial fixation, a rare condition, but it has a lot of problems because you really need to operate them after 1 month of such situation. But if it is not a very long period after occurrence of the disease, you can use derotational system. You see dislocation, kind of dislocation of C1 on C2. So you can put traction and derotation. So it's very simple technology. You can use it anywhere in India, in every hospital, with no any confusing or expensive hardware. What about Ilizarov ideas in septic conditions? It is very useful in septic conditions. There are some publications, not a lot, so we are looking forward to publish our about spine, X-fix in spine septic conditions. And I'll show you some cases. This is 2 years boy, paraplegic, with congenital abnormality of spine, with big ulcer, and plastic surgeons tried for 1 year just to fix this problem. You see there's a lot of attempts to cover the ulcer with no any success. So he became septic, of course, osteomyelitis, and you see the deformity is very huge. So they asked me what we can do. Maybe we got some Ilizarov ideas to fix the problem. So we apply this simple X-fix. The main problem that he had Arnold-Chiari syndrome. So you must be very attentive interaction. But we create these good conditions for his skin covering. And this ulcer was treated only in 1 month and 2 weeks without any plastic surgery. Then we put Webster system. It is like cast, like external fixator, but it is internal external fixation, the same principle of distraction. You see that we don't go to the site of, at first, this first step, we didn't go to the site of infection. We put it on the ribs and pelvic only, because we were afraid of osteomyelitis. And then after 1 year, we go to vertebraectomy, so we cut this bone, make shortening vertebraectomy, apply this transpedicular system, you see like here, and made very good alignment, very good spine. So now he is 8 years old, so it was 6 years ago. So now he's a wheelchair, of course, but he's happy, he's not septic, he's a big boy with good brain. So we really used, it's like a parachute procedure in this case. The same case, you see, another girl, 13 years old. There are a lot of such children, really. And there is no chance to treat them, to apply at first any internal fixation or make osteotomy because their skin condition is very bad. The same situation. Again, another system, you see, it's a transpedicular and pelvic system together. First steps, 20 days, and we cover all these ulcers, which were for many years in this girl, and it was impossible to treat it conservatively. So we treated it in 20 days. Then we go to open surgery. You see, this is gibbous. We cut gibbous, make again shortening procedure, put the hardware, and succeed. You see there, sagittal alignment, compression zone. Of course, it's paraplegic anyway, but now she can sit. She can sit. Because these children really can't sit. It's a big problem. In some septic conditions, especially in paraplegic patients, Ilizarov frames are very, very effective to close their ulcers and to fix the osteomyelitis of sacrum and of pelvic. This is our septic department for 135 beds. Now we have a separate big building. It's an old one, building where is Ilizarov Museum and first Ilizarov cabinet. And it's specialized only in septic conditions, nothing else. So it's a usual treatment in this center for very bad septic conditions of paraplegic patients. So you see it's osteomyelitis of pelvic, and we made debridement at first, and then put it on this frame, and then very easily you can just close this wound when you're using these systems with no contact with bed and very, very comfortable care. Another case from our septic department. You see a big abscess and some metal inside. The abscess is anterior because of this implant failure. So we can't get away all implants because it will be absolutely unstable. So we go to external fixation, real transpedicular, and clean all and make debridement. You see, put it there, and then can easily, after everything is fixed, infection is fixed, we can go to internal fixation, put mesh frontally, and now this is the end, and 1 year after surgery, everything is fantastic, everything is good, very good fusion. So spine fix is a parachute procedure, first of all. So every surgeon, every spine surgeon must really keep it in mind that you can use it in a very bad situations. And external fixation is a very good tool in some research. So we can do research in plastic surgery, in allografts and things like this. How can be used separately in pediatric cervical spine conditions. But the main indications for external fixation is highly risky surgery. And it must be quickly replaced by internal fixation. And of course, as in basic orthopedics, it's excellent in septic spine conditions. Thank you very much.
Thank you very much, sir, for that excellent presentation. Now I request Dr. Sundaresh to hand over a moment of appreciation to Dr. Gubin and Dr. Bo.
Thank you. Thank you very much. Thank you. It's a great pleasure to be with you. Thank you. Thank you. Thank you. Thank you. And we have a present for you to, for your hospital. It's, please, can you take it? We have a present, so it's handmade again, Russian plate made of gold and silver. We can open it and show you. So it's for your hospital as a sign of our friendship and relations. So we use to do this in the Ural Mountains. And this is Ilizarov Center. And the sign of Ilizarov Center.
Wow.
You see, made in metal, gold and silver.
Thank you.
Thank you very much.
Thank you very much.
Thank
That
you
was a wonderful lecture.
for inviting
I
us.
think
Thank
I'll
you.
ask you to come on video for our January 2nd, 3rd meeting.
Okay, thank you.
Sundresh to hand over the memento to Dr. R. A. Agarwal. The last lecture for the conference, Dr. Harshad on proximal tibia fractures. So it's Dr. Harshad Shah who gave the opening lecture and the concluding lecture for the conference. Over to Dr. Shah.
Yes? Okay. All right. So, ladies and gentlemen, from the first lecture to the last lecture, from the most complicated lecture, I'll give you the simplest lecture, and probably this is going to be useful for all the newcomers and starters to start Ilizarov surgery on, and that is on tibial condyle fractures. Tibial condyle fractures complex are 4 and 5. MS Ramaya, you know. Okay, when you see this, when we plan to fix internally without seeing the limb, when we opened it, we saw that a lot of blisters were there. So internal fixation is out of question. Without blisters, when you think of internal fixation, immediately also you are going to land up into trouble, because whenever there is a metaphyseal fracture, the fracture of the tibial condyle is going to be very dangerous to fix internally. 5th and 6th particularly are difficult, right? So views, scans, suppose you have only this X-ray and you tell, okay, I will do like this, like this, like this, it's not sufficient. You need multiple views as well as scans to plan what you want to do. All of you know various methods of treatment. Most of you opt to treat with plates. That's because it's quite simple. You get an excellent reduction, you are very happy, you start mobilization immediately, and end results are excellent. The only problem is when disasters occur. When you put a knife on a tibial condyle fracture with a metaphyseal fracture, it is not infection. The skin tissues itself are so bad and stretched that the blood supply is not good, and it can necrose, leading to infection later. So we have these various methods of treatment. Now this fracture, look at that. Okay, you have not planned. So I had liked this very much, that if you fail to plan any orthopedic surgery, this is for any orthopedic surgery, you are planning to fail. That means if you do not plan properly or don't plan at all, then failure rate is very high. There, looks like very good reduction, but you can see that it is not good, right? So a lot of problems are there, you don't accept it. A simple thing, you're not doing Ilizarov surgery, that's all right. You get a tibial condyle fracture of this kind, you just put a couple of screws, debride, put an external fixator, keep the knee joint in place. I think that helps a lot. It goes a long way in correct treatment of tibial condyle fractures. Now, what do we do generally? Preoperative planning for such things. where to put the rings. For the femoral, that's the femoral, and that's the tibial. And you can see that the joint is reduced. So that's the general method of treatment, what I showed you that time. Now if you get a fresh tibial condyle fracture, you want to wait for 3 weeks, 4 weeks, or maybe minimum 2 weeks before you want to plate. So you're waiting, and then the fibrosis reduction, everything is not as easy as you think. This is easy. You take the patient into the OT as early as possible. Knee joint, you aspirate, compress the knee joint, the fracture gets reduced quite well. And most of the time you can fix initially with screws. 1 or 2 screws will reduce the condyles where you know where to put the screws when you have taken a cross section. And this I think all of you are doing. Now the next problem is to see that the metaphysis is stabilized. To stabilize the metaphysis, you have seen so many surgeries now. It was an excellent presentation of all the foreign faculty who had come and taught you how to put the wires on the bone models as well as this. So all of you probably will go back confidently thinking that you can do Ilizarov surgery quite easily. Those who have not done also, but little bit of experience is required to see that you don't land up into complications. That is the rings which have been made because of the edema and the big limb. We take one size bigger rings and check on the C-arm. That is the ring there, that is the ring there, and then this is the ring at the ankle joint. You have seen most of them, experienced orthopedic surgeons here do not use C-arm at all. The reasons are obvious. Their confidence level is very high, their experience is very high, but then I'm in a teaching hospital where my students, if I do it like that, they will keep the C-arm outside and put the screws into the knee joint. I don't think that should happen. That's why it's better to check every step of surgery. And once you have done this, you just have to mount this frame. You know that 2 finger breadths have to be kept away from the front and there must be sufficient space below. That's it. One wire which we have put with an olive on one side. You've seen these pins. Just 2 pins are enough if you have fixed with an intercondylar screw. So if you have put 2 pins, that's more than enough. After this, these 2 you can fix it with half pins there. You know how to put half pins onto the medial surface of tibia. You have learned how to connect it to these rings. Or you can even put an AO rod and connect it to AO and make it a hybrid fixator. It is so simple. Aspiration of the knee joint, compression with S-marks bandage, 1 or 2 screws for tibial condyle for reduction of the tibial condyles, 2 Ilizarov wires there, fine wires, Ilizarov wires, and tension them. You can tension with your hand if you don't have a tensioner. The Russians have taught you how to do that today. And then here, if you have the expertise, you can put more pins, otherwise you can put half pins. That's it. It's very simple. You need to check under the C-arm your reduction, both AP and lateral view. That's it. You see the reductions, you are happy that the alignments are good, and you are done with it. Okay, we have had plenty of experience with these things. Most of our postgraduates are doing these surgeries by themselves. We have done only Ilizarov fixation in some patients with cannulated cancellous screw, bone grafting. At the time of removal, we have done infiltration in some of them, and external fixation is not for a very long time. 4 months is the general time. Very, very good results. Okay, it may be comparable with plating also, right? You can see the literature that fine wire is better outcome. The whole world is changing from internal fixation in spite of MIPO, in spite of titanium implants, in spite of percutaneous kind of plating. Still, the complication rate in plating is very high, and they are slowly changing from plating to fine wire fixation or Ilizarov. The Western countries slowly do not want to give so much credit to Ilizarov. So from Ilizarov to fine wire external fixation, you can see it is favored. All of them. The complications are much higher with open reduction and internal fixation. You will get many, many papers supporting the external fixation. You will get many papers supporting the plating fixation also. So amongst all these things, what is the kind of treatment that you want to choose for a tibial condyle fracture? I think everybody must be treating at least one tibial condyle fracture almost every month. So when you get a chance for Schatzker's type 1, 2, 3, 4 is all right, but 5 and 6 and compound fractures or other kinds of complicated injuries, you have options. You start thinking, how should I treat this? You look at the end result. Don't look at how you are going to treat this. Look at the end result. What is the end result that you want in your own limb? You want a good external functions, but no complications at all. Putting a plate on such a thing, there is a high risk of complications, and the plates also fail. You have seen time and again, so many presentations have been done here, and everybody is against all of us. So what do you want to think? You want to think that you should remember to see that there are no complications. All these big guns who had come to Goa, and all of us, I think, agree that tibial condyle Schatzker's types, even Dr. Bari and others, all of them treat by Ilizarov method. These are some of the complications. Amputations by Ilizarov, I don't remember having done, but I have amputated one tibial condyle which was fixed by a plate, got infected, very bad, very bad. Patient's condition became so bad that amputation was required. I've never heard of that, but then this is how it is. And nobody is going to report all such kind of things. I was telling you the other day, you will report only what good things you have done. Some examples. There. Decent results, very good results, comparable with either plating or by Ilizarov, but the complication rate is very less. You can see that we use this tibial condyle fracture also to see that it works like a high tibial osteotomy for a medial compartmental osteoarthritis. So incidentally it has occurred, so you use it and see that you give a slight valgus. This is an interesting case. This Jawaharlal told me that, Dr. Shah, your treatment is very, very nice. I enjoyed your Ilizarov treatment. Not many patients do that, but then, well, this is so many fractures, whether it is type 6 or 7, 8, 9, 10, 11, 12, I used to say. After putting Ilizarov, you see this reduction is very bad. If you put a plate and if this reduction you get, it's going to be difficult. That much of displacement. Now, what do we do with Ilizarov? Post-operatively, you just adjust it, correct it, you can see there. You translated it. What's happening? No, not moving. There, that's the end result. That's the brilliancy of Ilizarov. You're not doing anything, no incisions, no nothing, just wire fixations, right? So you can do so many things with Ilizarov. The advantages of Ilizarov is you can do all these things. That is minimum internal fixation, it allows knee movements, minimum invasive surgeries, fracture reductions, and then alignment of the fracture, union of fractures, but no gross complications, right? So why you don't want to do Ilizarov surgery? Compliance is something which they say. I've got so many photos, videos. This is 5 days afterwards. Very, very comfortable, and we wouldn't have done so many Ilizarov surgeries if the patient was not comfortable. One thing you must learn, never to give pain to a patient. If you give pain, the Ilizarov rings come out the next day. So no pain must be given to them, and it is painless. So what do you want to choose, ladies and gentlemen? Ilizarov, hybrid, or plating? My choice is to choose any treatment where you have minimum complications, for which in my hands with Ilizarov surgery I have minimum complications. With a hybrid, it's a very good method of treatment, particularly for those with less experience with Ilizarov. The only problem is whenever there are deformities at the fracture site and other things, it's not so easy to correct with this. And this gives excellent results, but if there is wound dehiscence, infection, it's highly dangerous. So I would still choose Ilizarov. Choice is yours. This is all the Ilizarov mantra. Finally, again, I repeat, we can treat tibial condyle fractures with minimum complications. What looks very ghastly and big, you can get excellent results out of treatment. So I think all of you should be able to go back home and start Ilizarov surgery with compound tibia fractures, tibial condyle fractures, and then graduate yourselves to go up to, I think, spinal fractures. I don't know. Spine is still a very virgin land. I should thank Dr. Sundaresh, Dr. Prakash, Dr. Kaushik and their team for such an excellent organization and arrangement. And I think all the foreign people, the faculty of the greatest kind have come here. All of you must have benefited very much, and I hope that all of you will go back home with great memories and start Ilizarov surgery, those who are not doing, and those who are doing will improve very well on that. Thank you so much.
Thank you very much, sir.
Many more like this.
Yeah, I now request Dr. Sundaresh to hand over the memento and certificate to Dr. Shah.
Thank you so much, sir. Thank you. You can take a photo of all the faculty. Yes.